This is an intriguing subject, the fact is that it's not in the guidelines. As you know, most surgery are diagnostic surgery with indeterminate nodule, and that is the reason why we decided that we had to investigate if was a contraindication or if it was possible to select a subgroup. Because this is an old, very nice paper which shows that complications in surgery are frequent and are more frequent when you have a total thyroidectomy. You see the yellow bars or a lymphadenectomy. And in our experience, it's very unusual to have a laryngeal palsy, as I saw in the talk before, while it's quite frequently to have a problem with calcium or with voice in patients who underwent surgery. But at least in Italy, for indeterminate nodule, very often surgery has a diagnostic role. The problem is a problem we consider for many years. We have a thyroid center which takes care of a lot of people. You see here, in 1 year, more or less, our division makes between 1,000 and 1,200 biopsies. In this group here, we took this group, 15% was a type 3. They went to surgery and just a little few of them were cancer. So we published this paper on about 1,000 patients with nodules which were operated, and we showed that there was a subgroup of nodule of which, on a morphological point of view, just looking with experience at the cytology, at the standard cytology, was possible to distinguish the higher risk type 3 with a 23-25% of probability of cancer, and a low risk type 3. We were talking of a paper of 2008. In Italy, at the moment, the psychological classification put type 3 all together. And in United States, the Bethesda was still before. After that, there was a sort of rethinking about the subject. And you see that in 2014, in Italy, we tried to distinguish these two groups. Type 3A with a low risk of cancer, about 5%, between 5 and 10, depending on the experience of the pathologist, and type 3B, which go much higher, 40%, 30, 40 in our hospital. Type 3B now is 45. And this was shown by a paper published in which they realized that the Bethesda type 3 have had a good or a moderate agreement, but there was a low agreement on the low risk type 3. So it's not easy for the pathologist to choose which part. And if you repeat the FNA on all the group of type 3, in this paper here, you see that 42% of previous type 3 become type 2. 4 and 3, so 7% become at higher risk. And so there is a reduction of this group if you review them. A second way to increase accuracy of diagnosis is to use the core needle biopsy. The Korean publish a lot on this subject, and you see here that the repeating of with core needle increases. You see, this is the standard. This is core needle increases on one side and a number of nodules which are considered after core needle benign, and increases also the part which are considered type 3B or type 4. So reduces the portion of really of true undeterminate. For this reason, we entered in the molecular testing phase. This was the timing of what happened in these years, and this genomic test showed immediately that we were very strong in negative predictive value. So they had a very strong role in ruling out, not so important in ruling in. Both the Thyroid and the affirma. Both have this sort of strength in negative predictive value. But the cost is very high. I say, I wrote 3,000, but I know that sometimes it's also more. In the world, people try to select a subgroup. And this is what made the University of Milan, Professor Fugazzola, I don't know if you have read something of this group, they are quite active on this. And they, starting from the fact that there were some genes, we had an important negative predictive factor, they selected a subgroup of them, and they set on a system which makes it very easy to do it, very fast, and so low cost. You see here per sample, the cost is 300, 1/10 of affirma or Thyroid. Putting together the clinical data, and you see here the nodule size, larger are more higher risk. The euthyroid data, so the ultrasound classification, the cytology, and then the molecular data, it has been possible to separate in 3 groups these nodules here. So if they are genetically negative, they are small, they are with euthyroids 2 or 3, it's possible to go in the low suspicion group, and so to have a risk of as maximum 10%. Obviously, when we thought about this group of nodules, these had to be nodules treated as best as possible. So with the ablation of afferring artery and venous sample, treating all the periphery, so we used ultrasound enhance, and we tried to follow all the things we had known. I mean energy, I mean selection, I mean so we treated mostly small nodules. Let's jump over this because we designed this study, which has been published a few months ago. We asked the ethical committee the consent. We choose the patient in 2 hospitals. We did the treatment in 2 groups, 2 operators with the same protocol. and selected nodule like this. This is an Indeterminate 2 or 3 because it's solid. Were all solid nodules. Were 3 which have this risk here with an cytology that has the 3. This is galactin, okay? So galactin negative with this aspect here, and with molecular testing negative. We put together in the study 35 patients. This was the appearance, the basal appearance of one of these. I don't know why it doesn't start. No. Here is why. This is the vascular part, the base vascular pattern. This is the enhancer. This is the effect. This is what you see after you inject the ultrasound enhancer. You see that is very, very detailed, the pattern of the vascularization. And this is then we perform the treatment and we repeated ultrasound enhancer after the treatment. You see that almost everything is black, and this is the venous vessel where you can, during the treatment, go on and ablate. And this is what we did. Using these procedures, we had a good result. You see here, is as median value, mean value, and median value. And this was the biopsy repeated on nodules which were ablated. So some group of these microfollicular pattern without atypia were present, but were very little in spite of what happened before. And this was the response. You see, we followed all at 1 year, some 2 years, and they had a very, very significant reduction, similar to what we have seen in the benign nodular group. So, which are the conclusions? Indeterminate nodules are mostly benign, especially if you can select the type 3A for us, or I add to this subject the fact that is known and published, not only in Italy, this first paper, has signaled that cancer coming from a type 3 pathology are less aggressive, are less extended, and have a low risk. These first data, 2014, are published, have been republished and reviewed and confirmed in 2024 in Italy and in the United States. So when you have a type 3 nodule, if you can select, and you, in any case, make a mistake, you are not talking about an aggressive form. Second, surgery is not free from complication, and often, at least in Italy, but I think all over the world, has a diagnostic scope. So you have an intervention because you want to see the histological score at the end. Molecular testing, together with US score and nodule size, can identify a subgroup of type 3A or Bethesda 3 nodule, which have a very low risk of malignancy. And there are some recent molecular panels which are cheaper, and so with a good predictive negative value, and so they can use it. RFA has shown a good efficacy on this small subgroup preliminary study. optimal nodules volume and correct energy delivered, I go again on this theme, are important factors influencing final technical success. Data after 2 years of follow-up are similar to that well known in benign nodules, and we are confident that this subgroup can be considered for the treatment with RFA in future guidelines. Larger study are needed in other hands in order to see if what we saw is true. Okay, thank you.
More questions from the audience?
Yes.
Hi, thank you so much. Would you consider rebiopsy if a thyroid 3 large nodule with a firma benign?
No, in this case we did it just to see. We were curious to see what aspect would have the nodule. We rebiopsied it 1 month after. The
So
follow-up was 1, 6 months, 12 months, 24. So just in this case.
Yeah, but what I'm saying, before doing the RFA, would you rebiopsy if a patient has a large thyroid 3 nodule?
Yes, because routinely we biopsy twice.
Okay.
Yes.
Yeah.
Routinely, just in the whole nodule. We biopsy also the whole nodules, just once. But for, what to say?
Any other questions? Okay, Dr. Deandrea.